Lauren, do you have George he sent any CV or anything to you?
He did not, but I pulled up his webpage. Here, one sec. I am messaging it to you now, Dr. Rameshwar.
Okay, okay.
I just sent it to you in the chat. That's the link to his homepage.
Okay. Lauren is no longer at University of Miami.
So it seems. This is the page that he sent me a couple of weeks ago. Where is share screen?
Oh, so it's called Rowan University School of Osteopathic Medicine.
Yes. Why are you putting your, oh, because you're doing that. Okay. I was gonna ask why you're putting your mask on.
Oh, he has a video too.
Sorry?
Yes, there's a video here.
Yes.
So this place where he is.
My name is Dr. George Nahas. I specialize in bone marrow transplantation, and I work at Miami Cancer Institute. Well, I do bone marrow transplant for high-risk malignancies, particularly leukemias and lymphomas. So not only are there different advances in treating patients using bone marrow transplant, there's also another cellular therapy.
Okay, so Lauren,
Yeah.
you know what you could do? You
want me
could
to play that video in the
play that
meantime?
video to the students, yes.
Sure. Let's see. Now how, oh, I can't do both at the same time. Okay.
You can share it, right?
Yeah, I tried to do too many things at once and I made the computer unhappy.
My name is Dr. George Nahas. I specialize in bone marrow transplantation, and I work at Miami Cancer Institute. Well, I do bone marrow transplant for high-risk malignancies, particularly leukemias and lymphomas. So not only are there different advances in treating patients using bone marrow transplant, there's also another cellular therapy called CAR T-cell therapy, which is a form of immunotherapy where we would extract a patient's immune system and engineer that immune system in the lab and then infuse those cells back into the patient to then fight the lymphoma or leukemia with that engineered immune system. In previous training, I had one patient in particular who I probably learned how to treat a high-risk lymphoma through her. She had a very high-risk lymphoma. We last went through 5 or 6 lines of different therapy. We then brought her to CAR T-cell therapy, which were engineered immune system therapy. And we used that as a bridge to then undergo a bone marrow transplant. To this day, she is doing well. I don't believe that she would have had more than a couple months of survival if she had not even received the CAR T-cell therapy or even gone on to undergo the bone marrow transplant.
Okay. And he is logging on momentarily slash, I think, oh, hold on, that's the same video. It looks like he just signed in. Okay, awesome.
He's here?
Yes.
Yeah, I'm here.
Oh, hi, George.
Hi, Dr. Rameshwar.
Yeah, you know what? Before you came, I tell them everything about you. And
Okay.
we just played the video. We just played the video so they can know a little more what you do. The video that was on the website.
Right, okay.
Yes, and so as you talk to them, they will ask you question about different issue about career options and things like that. So if you have any advice also to give them, it would be great.
Okay.
Yeah, so guys, I already introduced Dr. Nahas. I think you learn more about him than any other speaker just now. We've been talking about you for a long time. I told them a little about your track. Lauren told them how you were the one who put all the effort into making your career, how you used to come in very early to do your experiments and how it paid off and things like that. So we tell them all of that.
Okay. Yeah, so I mean, do you want me to put up this PowerPoint?
Share. Yes, you can share.
How
You
do
can-
I-
Lauren, he has shared.
On the bottom of your screen, there should be a green arrow that says share screen.
Lauren was always good at the
I'm the
always good
IT person in the
the
lab.
technology, yeah.
And you're not here today to get any of our baking.
I do miss that. Okay, so
There we go. We see the top, oh, there we go.
yeah, so I don't know what oh, this is a new update to the Zoom. Okay, so I'm gonna I'll kind of just talk a little bit about what I do. I think I can see the classroom there. So, and I'm speaking to medical students, right?
So majority of the group is rising second year medical students from both RWJ and NJMS. We also have a rising second year dental student, rising second year PA student, and signing in, we have a handful of students in other areas of their training, in other levels of their training.
George, this program is a NIH funded training program
Right.
to encourage students to become clinician scientists like you.
Very good.
And that is why it was so good for you to come in to talk to them so they can see they could be you in a couple of years.
Okay. So then I'll back up and talk and go back a long time ago now. I won't say how many years. It's been a long time since I've known Dr. Rameshwar. So I'll start at the beginning. So I first met Dr. Rameshwar when I was entering my 4th year of medical school. I wasn't really sure what I wanted to do, but I always kind of had like a very an interesting kind of like very, very detailed mechanisms of how, I guess, medicine and different therapeutics could work. And at that point, jumping into Dr. Rameshwar's lab, she gave me the opportunity to learn a little bit about little bit about how the lab works. She kind of threw a project at me, and a breast cancer project, which was interesting, and I took it from kind of like a half-baked project and we took it all the way to publication, which was a nice result. So during my 4th year, I would end up doing clinical rotations, obviously, as you guys will run into, and basically around that, before and after rotations, I would go to lab and I would do what I had to do to get the project done. Interspersed with that was also a lot of writing, and Dr. Rameshwar is big on giving opportunities, or any good PI will give you opportunities to write as well, because it's, number one, really important to learn how to write scientifically, but it's also it makes you read, and it makes you learn about it makes you before you put your thoughts into words, you have to understand what exactly it is that you are that you're writing about. So, and then I went to a residency at NJMS, and again, my residency included, it's a tough residency, but in the morning, I got up early, went to lab, did what I have to do. In the evenings, back in lab, doing what I have to do. And on the weekends, coming in and, couple hours, Saturday morning sometimes Saturday and Sundays, do what I have to do to get certain certain lab work done. So and then in fellowship, I did at the University of Miami. So I was, so obviously I left the Ramachur lab, but I continued doing, some lab work when I was at University of Miami. I'll say that this is a perfect time to build a foundation for learning how the lab works, learning how science works, and learning how to publish anything. Learning how to publish, learning how to put an idea to work, and learning how to get that idea into how to make it work and get into final publication. Dr. Ramachur, she would always say this, and you don't realize how important that is until years later, when you are a practicing clinician who is involved with research, and that foundation of learning about science and learning how things work is really, really valuable. And you don't realize that until later on in your career, when when you're talking to you're talking to site initiation visits where a company is bringing a drug to your institution, and you have to understand, and they're trying to push a certain mechanism on you, and you have to understand what that mechanism is, and you have to ask the right questions to know whether or not it's worth bringing that drug to your patients. So just to back up a second, so I went down to University of Miami for hematology and oncology fellowship. I did 3 years down here doing that. I did a second fellowship in bone marrow transplantation and cellular therapy, including CAR T-cell therapy, which I can talk about a little bit later. And during the fellowship, I was fortunate enough to obtain my own grant, my own personal grant with regards to or funding, I should say, with regards to a grant that I wrote, a Young Investigators Award grant that I wrote regarding a complication treatment protocol for a complication for graft versus host disease. And this was a benchtop research project. And again, it goes back, to whenever you write a grant and whenever you want to, advance a science career, they always look at your background. When you're writing a grant, they want to see what have you done in the past and how capable of, before they give you money, they want to see how capable are you to actually complete a project. Anybody can come up with an idea, but if you don't have a well thought out idea, if you don't have a well thought out protocol, and on top of that, if you don't have if you don't have the background to do if you're proposing a basic science project and you don't have a basic science background, then they're not going to want to give you any money to do that, because they're going to say, why do I believe that you can do that? And then moving forward, where I am right now, I'm mostly a clinician, but I'm involved in probably 6 or 7 clinical trials right now. However, in oncology, you have to be roped into basic science, or you won't understand what you're doing. And that's another reason to kind of, I'm saying this now because I understand how much, especially now, I understand, and I'm grateful for how much basic science background I had and how much writing I did in the past, that really built a really strong foundation for what I'm able to do right now. And I'll tell you that, if you don't pay attention to mechanisms and the science and how things are done, you'll fall behind some of your colleagues, and on conversely, you'll stick out very positively to your colleagues, and how much science you know, and how much of a deeper understanding you know of how things work. And it, overall, it makes you a better clinician in addition to a better scientist as well. I don't know if that kind of covered a decent amount of what.
This was great, George. This is exactly what I wanted to tell them. But what you forgot to miss, there's a paper actually written here on the Musashi work that you did also, where you're first author on that too. So that will be submitted pretty soon, actually.
Oh, good.
Yes.
Yeah.
Yeah. So Lauren, at this point, before George began his talk, you ask them if they have questions for George.
Sure. Do you guys have any questions for Dr. Nahas at the moment before we start? So far, so good.
Okay, so yes, I'll just I'm just gonna go through. So it's interesting. When I was in medical school, I was always kind of interested in in kind of like the immune system and how the immune system works. Dr. Rameshar's lab is obviously, I know there's a pretty good, strong foundation in stem cell, which is obviously relevant to many areas of medicine. As you can, if you just read through Dr. Rameshar's publications, you can see that it's not just malignancy, but a variety of different fields of medicine as well. But also the immune system. I remember I was presenting a paper. I was presenting a poster for the Rameshar lab. I believe it was 2012. It was at AACR, and I went to a lecture by the name of someone. I presented my poster, and I was kind of wandering around looking at different lectures that were good, and I saw a lecture by this guy named Carl June, and I said, "Oh, let me go check this out." And it was a room of does anybody know who Carl June is? Just raise your hand. Anybody heard that name before? I can see you guys in the no. So I said, let me go check out this lecture. I went over to this. I went over to the room, and there's a room of me, maybe like 10 other people, and this guy, Dr. June, and he was talking about how he engineered T cells. He took a patient's T cells out. Specifically, the girl's name was Emily Whitehead. She had a specific type of leukemia for a toddler, a pediatric type of leukemia. He took her T cells out and he engineered them to fight the leukemia cells, and he gave them back to her. And this was the end product of years and years of research in order to do this. And he is, long story short, I mean, there's lots of side effects that this girl had experienced, but I think she's like 19 years old now, complete remission for years. Yeah. They just sent out an article about her. But this guy, Dr. June, Carl June, he's at University of Pennsylvania. He's probably going to win a Nobel Prize, I think, or he will be in the circles for the discussion for it. I think.
The problem is that he wouldn't get it because last year the Nobel Prize, because of the Nobel Prize was already given to bone marrow transplant by Donald Thomas, who he trained with. And then the immune therapy was given out, and he didn't get it because the immune therapy he's doing was based on what those other people got it did.
Right. I think you're talking about James Allison, Dr. Ramesh.
Yeah.
So I mean, so what Dr. Ramesh is saying, I mean, let's just be more broad. I mean, the idea of immunotherapy is certainly very relevant to the world of medicine. That it's if he doesn't win a Nobel Prize, then he certainly has been spoken about in the same sentence. But James Allison won last year, and I actually have a picture of him later in this slide. So I'll quickly go through these slides, just basics of immunotherapy. I just wanted you guys to have an idea of the potential of immunotherapy as a treatment modality for, this is obviously centered around, blood cancers, and also, other types of malignancies, but that's what I do. But of course it's relevant. So, has anybody heard of this guy, Dr. William Coley? So nobody's gonna, I can see you guys in here. So William Coley was a surgeon in New York City in the early 1900s, late 1800s, I believe. And he noticed that there's a patient he had this neck mass on, a tumor on his neck. And the patient developed a bacteria on the tumor, and the tumor resolved. So he said, that's great. I'll just start injecting all of my cancer patients with bacteria. So obviously that didn't have great results. But a couple patients actually had a little bit of a response to this, specifically a streptococcus bacteria. And this was actually the first, he didn't really know what he was doing. Nobody really could explain it. But in hindsight, this was probably the first time that immunotherapy was actually used. And what was actually happening is you probably had a cross-reactivity, antigen recognition of the immune system attacking both the antigen that was found on bacteria and cross-reactivity with antigens that were probably similar looking to on the tumor cells to the bacterial cells. So you had this cross, this kind of overlapping reactivity of the immune system to both of these antigens. And that potentiated an immune response. And that's probably what happened. And this is probably, if you look back, in some different literature, it's probably the first time that there's some sort of immunotherapy that was actually done. Of course, he didn't know what he was doing, and nobody could explain it until years later, but this is probably what was going on. Okay, let's go to the next slide here. So this goes along the idea that we have something called, there is a concept that we have something called immune surveillance. Your immune system does, and you've probably heard this before, your immune system does have anti-tumor potential. And the idea that the immune system kind of surveils the bloodstream and different tissues and whatnot in order to find cells that are abnormal, cells that are growing, so cells that are tumor cells essentially. And specifically speaking, you're looking at particularly T cells are very important, and also natural killer cells as well are also very important to that have very important anti-tumor qualities. And again, this was explained in Paul Ehrlich first explained this in the early 1900s. This was his early to mid 1900s when his career kind of explained some of these things. I know this article is written in 2013, but it's a review article. It's just a citation for the diagram. So years later, 1948. So not a lot happened in 40 something years. Not a lot happened, right? But then we have the cells make antibodies, and there's recognition that antibodies they target different antigens, and that they targeting these antigens, tumor cells or some sort of other insult, that also propagated the immune system against these certain antigens. Now we're gonna go this much further down the road. First monoclonal antibody for cancer approved, rituximab. This is a really huge advancement in science. So now we have these antibodies, and we can create these antibodies specifically against CD20. They're against B lymphocytes. So CD20 is, and if any of you hope that you guys are budding oncologists, you'd get very used to rituximab, which is a anti-CD20 antibody, and it kills off B cells. B lymphocytes, and particularly speaking, non-Hodgkin's lymphoma. It's basically the cornerstone of any non-Hodgkin's lymphoma. Any B-cell lymphoma, you're getting rituximab. So this is, and you're talking about, there's dozens and dozens of types of B-cell lymphomas. This is a remarkable achievement in medicine. Even with all the advancements that we have with non-Hodgkin's lymphomas, rituximab is always always part of the backbone for treatment. And this is coming from somebody who I treat patients in front line, second line, third line, fourth line, fifth line, whatever, what have you. It's always a backbone. It's even part of the conditioning regimens for stem cell transplant. This is an interesting slide I wanted to talk about too. This is Dr. Foley. And I'll tell you that a lot of these physicians, these physician scientists back in the, I recognize all these names from different review articles that I wrote with Dr. Rameshwar, because once you get these names pop up regularly. So this is interesting. So you have, I hope can everybody see my arrow?
Yeah.
Yeah. Okay. So the top of the slide, you have a mouse, and again, this is when you play with mouse models, it's a nice model, because you're really putting it into an in vivo, live animal, a full immune system, maybe not a full immune system, but a full animal that has lots of moving parts, not just a dish, but dish, in vitro to in vivo is a nice step, and then in vivo to in human is the next good step. So we have a mouse create a tumor with a carcinogen. If you remove the tumor and then you inject the tumor back into the mouse, I'm going straight down here. The mouse in this case, the mouse did not develop a tumor, meaning that the mouse probably developed, with decreased tumor burden, the mouse probably developed some sort of anti-tumor qualities with regards to their immune system. And when the cells came back at a lower burden, the mouse's immune system could handle those tumor cells and attack them as foreign, which is what we want. Now, if you take those same tumor cells and inject it into another mouse that has never been exposed to that tumor, that mouse will develop that tumor, because it doesn't have that immune recognition that mouse A had. Now, if you take that same, if you grow that tumor in a completely different mouse, and you inject it into mouse A, again, this is mouse A over here from the middle, that mouse will then grow that tumor. So you see that the mouse really the whole point of this is that this mouse in a straight line down here, this mouse A develops an immune response to that specific type of tumor, which is very unique to that type of tumor. And it will hold on to that memory immune system to then hit that tumor again. And quite frankly, that's a remarkable finding, saying that we can have, not only are you developing an immune response to a tumor, but you're also harnessing a memory response that can last over time. So let's move on here. So we move on to the 80s, and we see that T cells engage in tumor cell death. So T cells, we have a CD8 cell up here, engaging it in an infected cell, and releasing porphyrins would then engage the cell and destroy the cell through perforin. So we have a specific mechanism where T cells are now, we can kind of point our finger and say that T cells are a very specific mechanism that can engage tumor cells and provoke tumor cell death. Now, this is what I can't talk about immunotherapy without talking a little bit about PD-1. So this is mostly in what we find in melanoma, so skin cancer cells. You have your tumor cell. I'll try to make this simple here. Tumor cell, the tumor cell has to present an antigen, right? So there's a balancing act. PD-L1 is a marker. It's a stop sign marker for the immune system. So there's a balancing act when tumor cells. So tumor cells are, and this is something that I think it sometimes escapes us when we. And to tell you the truth, unless you really deep dive into this, I think I will say a lot of my colleagues even don't really understand this either. The tumor cell immune response, tumor cells are very similar actually to to regular looking cells. All right, there's more similarities to a regular cell than say a bacteria. So an immune system sees a bacteria cell, they say, oh, that's a slam dunk, this is bacteria, I need to kill that off. But tumor cells, they get smart, they hide, they know how to hide, they can create different issues. They can create different stop mechanisms. Regular cells have PD-L1, which is a stop sign marker. And your cells, the T cells engage the stop sign marker and it says, oh, there's a stop sign, I'm done with this, I'm not gonna attack this cell. And if there's more stop sign markers and not really any antigens, then the T cell will leave the tumor cell alone. If the tumor cell is a little bit, if it has a lot of antigens that it's presenting, tumor-associated antigens, and it has a decent amount of PD-L1, it's a balancing act. You kind of need more of these antigens to really overcome that. So something that kind of overcomes that boundary is a PD-1 antibody. So this PD-1 antibody will block this signal. So the T cell is really engaging really just the antigen. And yes, it can attack normal cells as well, but if there's enough, there's going to be more antigens on the tumor cell than on a normal cell. So the balancing act is really swings over pretty heavily over towards the normal cell, towards the tumor cell. And that's kind of like the beauty or the balancing act of this PD-1 axis. CTLA-4 is pretty much the same thing. It's stop sign marker. There's antibodies now that fight up against CTLA-4. And I'll tell you, I got to the first guy to combine both of these, Mario Schnoll. He's I don't think he's at Yale anymore. I think he moved somewhere else. But something like this, it's late at night and you're writing a review paper for Dr. Rameshwar, and you're in the weeds and you're just reading and reading and reading about this stuff. The next thing you know, when you're interviewing at an institution and you're interviewing with Dr. Schnoll, Mario Schnoll, and you know this whole mechanism, it helps you in the long run. And it really when you have that really deep understanding, and again, this is coming from a science background, you have a different way of approaching these different topics. It really helps you, kind of understand things better, so you can talk about it better with, with different scientists. So this is obviously I have to get. This is James Allison, who MD Anderson, who basically, he won a Nobel Prize, also with Dr. Tetsuko Honjo, for this PD-1 axis that they had described, and it's remarkable because I spoke about it in melanoma cells. However, I mean PD-1, PD-L1, CTLA-4, all these agents are leaking over to lung cancer, to bladder cancer, to kidney cancer, to liver cancer. They leak over through all to all other different types of malignancy. So this is a really good, and I don't know if anybody has heard of this book called The Emperor of All Maladies, or has anybody ever heard of Siddhartha Mukherjee?
They should read it. Read it. Yeah.
Brilliant guy. He's also a stem cell transplanter, hematologist over at Columbia. I think he probably does more writing now. He wrote The Emperor of All Maladies. He chronicles basically the history of malignancy and tumor and anti-tumor therapy. Really fascinating what you can do, what you could get away with in the 1940s with with just treating patients, versus what you can do now. You need a lot of FDA, FDA and FDA allowances and whatnot to be able to do that. But he gave a TED talk and he said a couple of years ago, and he said, instead of killing something, can we grow something? And what he was really referring to is the immune system. Can you potentiate the immune system at such a level where you're not worrying about a chemotherapy that's killing the cell. You're worrying about increasing the potential of the immune system to kind of attack the tumor cell itself. And he also followed that up by saying that, he thinks that, maybe I don't think we're there yet, but in 20, 30, 40 years, we'll be treating cancers with cells and not with chemotherapies. And this is where it comes back full circle with regards to genetically engineering T cells against melanoma. You can see this is a CAT scan right here on the left-hand side where it says A. You can see tumor here. This is a patient's liver. You're looking through the patient's feet, basically. This is a liver. You see a tumor size here. And you see it decreases to almost nothing at this point. CAR T cells in lymphoma. This is what I do. I'm one of the lead investigators for a CAR T cell called lysocell for diffuse large B cell lymphoma. Now, CAR T cell achieves 92% response rate in chemo refractory. These are patients who don't respond to chemotherapy. 92% response rate. That's remarkable. That is an unbelievable response rate. And you see how early this is, but it's a fast-growing field. Yescarta, 2017 approved. Kymriah, 18. Tecartus in 2020. Breyanzi, which is lysocell, which is what I'm talking about, is just approved a couple months ago. Abecma is also approved as of, I believe it was this month or last month. That's for multiple myeloma. So these CAR T cells are gonna, they're kind of leaking over into other, into other malignancies as well. So the way the CAR T cells work is you leukapheresis, you take the patient's white cell T cells out of the white cells out of the patient. You engineer them to construct a chimeric T cell receptor, which is right here. See the T cell up here, normal T cell, chimeric T cell receptor, MHC antibodies. So what it does is it kind of, this whole axis here, it kind of supercharges the T cell receptor into one receptor. This is the beauty of this. And you basically you use transduction to have the T cells in a plate to grow their own, or to express, I should say, not grow, to express their own T cell receptors, and to target, in this case, to target the tumor cell. And then you expand them. You give a little bit of chemotherapy to leukoreduce, T cell reduce, to get rid of the patient's own T cells in order to make room for the new T cells to come in. And then you infuse the cell, one-time infusion, and you basically wait and see how it works. Now, have we seen something similar? And this is kind of similar to an allogeneic stem cell transplant. You give, and I'll simplify this a little bit. And this is also something that I do over at Miami Cancer Institute. This is an allogeneic stem cell transplant is when you ablate or you eradicate the patient's own immune system, their own bone marrow, which creates their own immune system, with high dose of chemotherapy, and you infuse a donor, a matched donor, whether it's a family, a sibling, or an unrelated donor, a matched donor, you infuse that into the patient's, into their peripheral bloodstream, and those cells make their way into the bone marrow, and those cells will then, after 10 to 14 days, they will grow into a fully functioning immune system and hematopoietic system that creates immune cells, red cells, and also platelets. Now, the benefit of this is this creates these new T cells coming from the donor. Those T cells will recognize any leukemia cell that might pop up from the recipient as foreign, and they'll kill it off. That's called graft versus leukemia effect. Unfortunately, it can also attack the patient's own body. That's called graft versus host disease. This is the what do they call it? The golden chalice of bone marrow transplant. How can we harness as much, the holy grail, I should say, how can you harness as much graft versus leukemia effect without having as little graft versus host disease as possible? And this is a question that has plagued the transplant world since Donald Thomas first transplanted in the late 70s for 40 something years. So again, CAR T cells is something that something that needs to be talked about more and learned about more. The one thing that I think, and again, and I ask this to every single person who presents on CAR T cells, I always say this. I say, are we so naive to think that by having a CAR T cell hit one antigen, and only the T cell response, are we too naive to think that we can just get this response without natural killer cells, without B cell response, without all these other immune system cells? And it's a good question because, quite frankly, when we have a fully functioning immune system with a variety of different immune cells. So, it begs the question, and now, and interestingly enough, and this is my last slide, so I'll end on this. But interestingly enough, that is a question I've asked to some what's his name, Rainier Brengens over at MSK, who's a big CAR T guy, brilliant guy. And he told me, I asked him last year the same question. He said, I'm not sure. That's a really good question. Maybe we are too naive, and we need to actually move forward and try to harness other immune system potentials as well, in addition to T cells. I'm going to skip over this slide. This is kind of like what I was talking about here. Look at all these immune cells that probably aren't being really paid attention to too much yet. I will tell you that natural killer cells are being paid attention to at this point. They're very relevant. There's studies out there that try to potentiate natural killer cells or NK cells up against cancer cells, whatever malignancy we have. But that's something that's also being explored as well, in addition to the T cell. Okay, and always remain. I took this from this is a leftover slide. Always remain willing to listen to clinical trials. And this is my my team over at Miami Cancer Institute, which we are very motivated to have a lot of. We're trying to become a pretty big immunotherapy center, which is one of the reasons why I came to this site. But to go full circle, and I hope that was and then I don't know if you guys need to take any notes from that. I hope not. But the important thing is just to know that this is a long road to be able to get to this point. But now's the time to really form a foundation of your science knowledge, because it's hard to read about this stuff later. It really is. It's hard to get I shouldn't say it's hard to read. It's hard to get a really deep background for it later on in your career, because you're going to be very busy. And I tell this to all students. I have students from FIU Medical School who come. I tell this to all students, when you're attending, you're going to say, oh my God, I had so much time when I was a fellow. When you're a fellow, you say, oh my God, I had so much time when I was a resident. When you're a resident, you say, I had so much time when I was a med student. So this is a perfect time for you to really get into the weeds and really understand, where you are, really understand the deep science behind a lot of these things, and it will serve you well. I've run into the most impressive, and again, I'm in a very science-driven field, being oncology, but the people who really go far are the ones who have a very deep understanding of, and spend some time in the lab too, to really understand how things work. And I know, and also to really understand the time of how much it works. And I know in the lab we'd always joke around. I remember Steve Greco, who's another a name from the past from the Rameshwar lab. He always said that when you have one data point on a graph, it's unbelievable how much time goes in that one data point. And he's right. Sometimes it takes 2 months of experiments to get the one data point. But that one data point forms a foundation for the rest of the graph or the data set that you're trying to form. And it's important to know, to also have an appreciation for how much work and how much effort goes into that. So I'll take any questions. I don't know. I hope I didn't kind of get too tangential with everything. But I still give. I gave a talk almost identical to this to other physicians who are in my position. So, I'm talking to students like you guys, and now, physicians. So it's important for everybody to kind of, it starts with a good foundation.
So George, this was great. One of the things you made a very important point at one point, that interview you had at Yale. And I hope the students have this take-home message, because if you're going to be interviewing at a competitive program, you're going to be interviewed by people who are doing research, and you have to be able to speak intelligently. Because you have to show your worth to them, because they're in the business of training people like Dr. Nahas. They're not interested in training people for the general community. Other hospitals will do that. So because you're in this program, you probably have decided already to be in the next Dr. Nahas, for example. And I think that interview that you talked to them about Yale really underscore the importance. And I think, George, that's also even helped you when you went to the interview, even for residency, because by then they knew you were on your way to this. And even up to today, I want to tell all of you, Dr. Clapp will talk about George all the time up to today. So people take notice. As you remember, Dr. Nahas said, you can either stand out for the good reason or the bad reason. So you want to stand out for the good reason. The other thing I want to tell you, George, that they are all in labs, actually.
Oh, good.
Some are there in labs, and the idea of this 10-week is that they can develop a relationship to their mentors, and they can continue doing their research. And we're going to have, over the 4 years, we're going to have some podcasts, like people like you coming in and make podcasts for them. And so they can listen, because when they say, like, they no longer go to Hackensack, because we're now part of the Barnabas healthcare system. But as they're doing their rotation in third and fourth year, they'll have these things to go back to. And the other idea is that all of you who are coming to talk to them, if they went, as they apply for residency or they want career advice, we're encouraging them to reach out to all of you.
And Dr. Rameshwar also, and you can look at, past people in Dr. Rameshwar's lab went to very good programs and very good research-oriented programs. And they were people in the lab, Bobby Reddy, Sean Patel, Kareem. I mean, everybody had really strong, research backgrounds. And the other thing that is interesting to mention too is that you also will learn how to talk to other scientifically oriented people. So I know something else that I didn't know, that you guys don't go to Hackensack anymore, but through Dr. Rameshwar, I got a chance to meet Dr. Scott Rowley, who is very scientifically oriented with the way that he approaches his field of medicine. He's also a bone marrow transplant physician, and I think he likes me, or I think he likes me, but he was a good person. When I spoke to him, I kind of knew how to talk. He had a lot of people who went to him to work on some projects with him, and they didn't really know how to kind of like, I think he was unimpressed with them, quite frankly. But when I go to him more with a scientific approach, there'll be these people, especially who are more scientifically oriented, they'll be a little more willing to give you their time, because you're going to know how to talk to them as well. So really, this is a great. I'm really happy to see a lot of you, have decided to kind of hop in a lab, try to gain some experience, and kind of build upon this kind of scientific background and scientific for lack of a better description, a personality that you'll form, because it will help you in the future. And it's a long road, but you'll there will be a point where you look back and you'll say, wow, that was really, that was phenomenal that I did that. All those late nights and those early mornings, those weekends, it's really great that I put the time in to do that. It will be worth it.
Yeah. George, they also had a trip to Johnson & Johnson because one of Nick Pangio's students is one of the main patent lawyer, and he was able to arrange for them. And the top physician scientists that work for Johnson & Johnson, 3 of them get to come and meet with them. So they get that feeling to see they can also have another career. And they were able to see a CAR-T. So students, just so you know, that CAR-T lab that you visit, that's what Dr. Nahas was talking about. That's where the T cells are being engineered, actually. And also, George, one of the key things that you said today is that immune checkpoint therapy. I've been asking the same question to everyone. You're giving immune checkpoint therapy, and to what? You have no immune system at that point in these patients. And so you have to do something. And so, George, at some point during the future, I'll talk to you about what we're doing with the aging study. We've changed it a bit from when you were here. I'll tell you about it. And so I think that should be combined with the immune checkpoint therapy. Of course, there's the danger of getting even worse autoimmune disease, but
right.
Yes.
Yeah, and as the immune, so that's a really good point, Dr. Armstrong said. As the immune system ages, that PD-1 axis becomes altered. So there's all these questions about, there's a research interest right now, is how do we rejuvenate this PD-1 axis, through some sort of anti-aging mechanisms. And that's a huge field of research right now. It's really important to understand that.
Yeah, well, I'll talk to you at some point before the summer is over. I'll tell you. Yeah. Okay. Okay. So, Lauren, sorry.
Not a problem.
Lauren, before we open the question, Umberto is here.
He is zooming in from his office.
Umberto. So, Umberto, do you want to tell George what you're doing? Because Umberto is George. Umberto is very key in mentoring students. He had the NERA program. Umberto, do you want to say something? Is he there?
I'm muted. Okay, I'm unmuted now. George, nice presentation. Thank you for sharing the information with our students, both our medical students and as well as our pipeline program that are here to learn from the different experiences you guys have. I know that part of where you said that Dr. Ramoshar was helping you with the scripts and manuscripts and stuff like that, and different type of projects that you were doing. I think that I'm sure that more of our students will be connecting with Dr. Ramoshar and asking for more projects to do, because at the end of the day, that's one of the skills that we don't tend to learn in college or medical school, but it's one of those attributes that can push forward science and medicine at the same time. And I think that your experience allows for them to see that that's possible, and how, I won't say easy it is, but how possible it is as long as we can see it and realize it as well.
Great. And Umberto is really big, a champion of training these students to become clinicians, physician scientists. He's a big champion of this.
That's good. That's, you're doing a good thing.
Yeah. Lauren, can you ask them if they have any question? They have a great opportunity here to ask. They can even ask career option question too.
Anyone have any questions they'd like to ask Dr. Nahas? Come on up to the mic.
Can George see them now, Lauren?
Can you-
It's on this computer.
Can you take the presentation down, the screen?
Oh, I think George, you may have to stop sharing.
Yeah,
Oh, sorry. Stop share. Okay,
there you go.
done.
Okay, George, so George, can you see who is asking a question? I can see him, yes.
Yeah.
Yes.
Can you hear me?
Yes, yes.
Hi, Dr. Nahas. My name's Jacinto. I'm an MS2. I was wondering, since tumor cells divide a lot more than regular cells, is there a chance for the PD-L1 to mutate over time and causing it to not be able to bind to the antibody and then, not being as effective as it normally is?
Could the PD-1, could it mutate over time? I'm going to answer your question. I think so I'll answer your question by going through probably what's been described as immune escape, is that the PD-1 will stop working because the cells, the immune system cells, the tumor cells will create basically, so there's two ways to go about this. What happens is that the biggest mechanism of what we would call immune escape or lack of response for these PD-1 agents or this PD-1 axis is what is called T cell exhaustion, meaning that the T cells will then, they basically become a muted response, even in the setting of that blocking antibody. Now, with that being said, with that being said, you have an aged T cell. So that also goes into line with what Dr. Rameshwar is kind of hinting at before is rejuvenation of the immune system. So you have strong T cells. Now, that also goes to play, if you think about it, and I don't know if I'm answering this question directly, but I think that's actually what's going on with regards to immune escape. It also kind of makes sense because, quite frankly, who gets melanoma? 8-year-olds don't get melanoma for the most part. Melanoma is going to be, your typical melanoma patient is going to be 72 years old coming in. And the question is, well, why are they developing melanoma? Let's say a patient doesn't have sun damage or significant sun damage. The theory is that it's an aged immune system, a T cell response that's not as strong or not as effective as a T cell response would be in a younger patient. So that's probably what's actually going on, is that the T cells become, for lack of a better description, exhausted, and they don't have, even in the setting of that blocking PD-1 antibody that's blocking that stop sign signal, you're actually, the T cells just aren't strong enough.
George, correct me if I'm wrong, but I don't think it's been reported that there's mutation of PD-1.
You're right. It's not been reported.
Yeah, one of the things that actually George have results in his paper that's going to go out, that he find a patient could be tested as the negative for the ligand, the tumor, but that small population of cancer stem cells did express that high PD-1. And that's part of his data in his paper, to show very high density of the PD-1 ligand on the cancer stem cell population. And asiento, that population don't proliferate a lot.
Yeah, that's so, and even more so what Dr. Rameshwar is saying, if you really look at these heterogeneous tumor populations, the cancer stem cell, let's say you have a specific tumor, there are some, I think even in some leukemias, like the AML cancer stem cell is like 1% of the population. And that's a cell you really need to target. So if you're targeting a lot of the cells that are more differentiated, that are further down the line, you can kill them off, but you're not getting rid of the main player, which is a cancer stem cell, which is Dr. Ramich is saying has those, has a different phenotype than the rest of the tumor.
Yeah, and Jacinto, more and more now, they're showing that even those cells that are more differentiated, that Dr. Nahas is talking about, the microenvironment are releasing secretome and de-differentiating those cells into cancer stem cell. And so those cells are not proliferating a lot. So I think what the general consensus that students are learning about cancer cell proliferating a lot, they, is as you start to get more in research, you're really finding what you're learning.
Yeah, and that's as someone who's we see a lot more of these therapies come out. They're not really coming out with more chemotherapies. They're coming out with more targeted therapies. Anybody can give. Any relapse patient I have here, I can always give them some random chemotherapy drug just to kind of blast everything. But that's not very nuanced. You really want a targeted therapy. And again, I treat a lot of myeloma and lymphoma and leukemia, and all of these agents, for the most part, I mean, we still use chemotherapy, obviously, but everything is really kind of gearing towards more targeted, more targeted agents. Good question, though.
Thank you.
Because we have a student actually in Sridhar. Remember Sridhar Ganeshan at CINJ? He's in his lab. And Sridhar does a lot of precision medicine. So I think he's going to be learning a lot about precision medicine. Alex, right? Alex started working in the lab already, Lauren?
Yeah, he started earlier this week.
Okay. And Lauren, any of them have any more questions? I can't believe they won't have any question. God, this was a great talk.
Let's see. Well, I think a question that was asked earlier that now someone is too embarrassed to ask is, how do you recommend that the students find the time to keep a foot in the research door during medical school?
You make time. You make time. I mean, honestly, it's not easy. I mean, science is not easy to do. But if there's a will to do it, I mean, you make time to do it. To tell you the truth, I mean, I can't tell you how many times. I mean, just if you're just simply talking about, say a Western blot, I mean, there's incubation periods. You set up, you set up an incubation with antibodies. You have an hour. You put it in the corner, then you walk over to your books. You do 45 minutes of questions or studying, and then you go back, and then second incubation period is 30 minutes. Then you go back and you do another 30 minutes. I mean, you make time. I mean, honestly, being in the lab, I mean, of course, if you're in medical school, it's hard you can't be in the lab from 9 to 3. But you make time. You go, if you have to be somewhere at 8, you show up to lab at 6. And I know it sounds early and it sounds crazy, but that's what I was doing. And then you go at the end of the day, and if you're out of clinic by 4 or 4:30 or something, then you go, if you have to change, if you have to change media, or if you have to, change chemotherapy or change the wells of chemotherapy, it takes 30 minutes. You go in, you get it done, and you leave. I mean, it's not easy. I mean, I know time is limited. I know you say you have a lot of time, but I mean, I know you really don't. But you make time. There's kind of like, there's a will, there's a way. I mean, there's a you make time to do it.
There's no formula. There's no formula. Even for people who are not in medical school like me, I had to give up, to build this career, I had to give up a lot of things, social events and things like that. But you have to know what you want and what you're willing to sacrifice to do it. So there's no formula. No one can actually tell you what to do. You have to be able to listen to all these talks that's coming in and realize that everyone makes some sacrifice one way or the other. And you have to decide how badly you want a career. What's your end point? What do you want when you're 40, 50, 60 years? And are you willing to give up something for that? And that's the basic question. George, correct me if I'm wrong with that.
Yeah, it's not easy. But but again, I think that it's something that it will be rewarding in, later on, down the line. I'll tell you that when I was interviewing for fellowship, I would say that most interviewers looked at what I did during residency in my last year of medical school, and I wish I started earlier in medical school, but I didn't. And then they said, how did you do all this, like in your during residency? And I said, well, I woke up earlier or stayed up later. That's basically what it is. You make time. You will make time to do it. And it's not about, at the end of the day, people, they want to see publications or whatnot, but more important is kind of understanding how science works and being able to, and I'm sure, Lauren and Dr. Rameshwar, you see people who have a lot of publications and they don't know what they're talking about because they weren't engaged. Whereas sometimes somebody has 1 or 2 publications and they were really engaged in the project, and they really know what's going on. And those are almost the more impressive people because they have a really deep understanding of what's going on instead of like having, fingers in just only a couple things. They're not truly engaged in something.
When Shakti went to do his residency, he was in a lab with other people. He was in the program with other people. 6 of those people came from fancy name school and they weren't able to cut it because they came with this amazing publication, but something was very wrong. So there was they were not really their publication, obviously. And something.
And that happens a lot.
Yeah, yes.
Yeah.
So any more question? I mean, this is a great opportunity for the student because George, what they're seeing, like Jesse came and talked and was very engaged with. Jesse has an MD PhD. So here they're seeing you who are now can talk to these pharmaceutical people who want to do this clinical trial with scientifically without a PhD. So they have to learn that they can still become scientists, but there's a different way of doing it and a lot of sacrifice to do it.
Of course.
Lauren, do you have any more questions in that room?
Does anyone in here have any more questions, or if anyone in the chat has any questions?
Lauren, you can get my email out if somebody wants to, ask me a question over online or something. I don't mind.
Awesome.
You're getting my email if somebody's too shy.
Yeah, George, put your email in the chat for them then.
I can do that, yeah.
And in the meantime, we have a student coming up with a question also.
Okay.
Thank you so much, Doctor, for your talk. Just a follow up to Jacinto's question about your targeted therapy. I was wondering, would you usually give chemo first and then do targeted therapy, or what's the order typically for patients that have, I'll say, lymphoma, for example, because I know it could vary depending on which cancer you have.
That's also a really great question. You have to follow, you can't just do whatever you want. I mean, you have to follow like NCCN guidelines and different, and protocols. First line, if you have your most generic lymphoma, first line therapy is chemotherapy. You have to give it because you can't just give like a CAR T cell to someone because it's just not insurance won't approve that. But I mean, the question becomes, and I get this question from patients all the time. They're like, well, if CAR T cells are so good for my third line therapy, why the heck am I not getting it first line? That's a great question. CAR T cells now, only this year for lymphoma, for example, they're really pushing for it for second line now. They're saying, why are we doing chemotherapy in second line? We have CAR T cells. And that's a good question. There's some recent data showing that maybe that's the better thing to do than chemotherapy for second line. But I think that as time moves forward, we'll kind of figure that out. But that's a good question. It's unanswered right now, but I think that people will, we'll try to figure that out as the years go on.
I have a question.
And it's very expensive. It's really expensive.
Yeah, I didn't want to say that.
Because a lot of these students who take the stem cell class, they're being hired actually in the manufacturing of Novartis, Bristol Myers, and all these places. It's a factory And it's a
That's actually-
very
it's a-
expensive factory.
I was just going to ask that. Do you actually see this as a possible second generation therapy, second line therapy in the remote near future, given that we still can't scale the production of the CAR T cells?
If insurance allows. These are, I mean, these CAR T cells are $300,000 to $500,000 to $800,000 for a dose.
Right.
So yeah, so that's like the other thing that's a little bit that's another lecture.
I mean, I'm not
A
even,
financial lecture.
I mean, I'm not even thinking of the cost. I was thinking more just the manpower of producing them.
So
But
that's a good question too, because I have patients who, what happens is the company, they give you slots.
Mhm.
I guess from the industry side of things, manufacturing slots. So if they don't have the ability to manufacture cells, then they can't put a patient on the therapy.
Right.
And you're right, as my clinic is full of relapse patients, and if I can't get them a slot, then they can't get therapy. So that's
Because
something else that's going to have to be dealt with.
Yeah, I got a good insight now of the manufacturing. It's they can just do 2 patients per week sometime. Now they're trying to do 10 patients per week, and it's very costly, really costly. Because George, when they open a bottle of media and they start manufacturing, they don't use that, reuse that media. Once they open, it's all get thrown out, and that cost go back to the patients.
Yeah. Yeah, that's true.
It's
What is worrying me that is going to happen, because it becomes such a factory. It's like a factory. They're going to take high school students now, and they're going to use those students in this factory. So they can. So the idea is to bring down the cost.
Well, and I think the important thing to take from that, I think, guys, is really just that as much as it's always important to see the progress of any kind of therapy in the clinic, we also have to remember the progress of the therapy outside the clinic. And in the case of immunotherapies, this really it seems to be the future of medicine. It just the production has to catch up.
Yep.
Okay. Are there any other questions? If anyone in the chat has any questions.
I put my email in the chat too, if somebody wants to ask me a question later.
Yep. And if anyone doesn't catch the email and wants to reach out to me afterwards, please do. I can forward that information. On that note, I think that's it. Thank you very much, Dr. Nahas.
All right. Thank you for inviting me.
Laura, let them unmute and clap.
We just did on my computer. Oh, you want people to unmute on their own computer?
Yeah.
I see. Thank you.
Thank you, George. Bye.
All right. Bye-bye.
Okay. Okay. I am. I'm just going to get rid of these people who aren't gone yet. As I am getting rid of these other people. Remove. Okay. So I think that is it. As a reminder, please send a email to me with a couple of time slots that you're available to meet to go over your specific aims, and have a wonderful day. Yeah. Which resident? Oh, your peer mentor. I just sent out another message to everyone. Oh, okay. Yes. Okay. Stephanie, I'll be up in a minute. Okay, I can actually just, let me, oh, Alex just signed up. Okay, I was just gonna check in on him. Okay.